Welcome, everyone. I'm Sophie Hogeveen, Data Access Officer for the Canadian Longitudinal Study on Aging, or the CLSA. Thank you for joining us for the CLSA webinar, Personality Traits, Health Behaviors, and Fall Risk, Insights from the Canadian Longitudinal Study on Aging. Before we begin, I want to acknowledge that the CLSA National Coordinating Center and McMaster University are located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. The university is located in traditional Blackfoot Confederacy territory. We honor the Siksikaisitapi people and their traditional ways of knowing and caring for this land, as well as all Indigenous peoples who have helped shape and continue to strengthen the university community. As attendees of this webinar, I encourage you to continue your learning following the webinar and to acknowledge the original inhabitants of the lands where we currently have the privilege to research, live, and work, wherever that may be. Before we begin, let's review a couple of housekeeping points. Everyone but the presenters will be muted during the webinar. If you need to change or test your audio during the webinar, you can click Audio Settings on the bottom of the Zoom window. At the end of today's presentation, there will be a question and answer session. If you have a question for the presenter during the webinar, you can post it in that Q&A box that's located in the bottom toolbar. These questions will be addressed at the very end of the webinar. The questions will be visible to all attendees. If you have any technical trouble concerning the webinar, please use the chat box to communicate with our webinar team. A feedback survey will be launched at the end of the webinar, and we invite you to complete it after exiting the Zoom session. This brief survey provides us with important feedback we can use to plan future CLSA webinars. Today's webinar is titled Personality Traits, Health Behaviors, and Fall Risk, Insights from the Canadian Longitudinal Study on Aging. This webinar will be presented by Henrietha Adandom, a PhD candidate in population health at the University of Lethbridge. Trained as a physiotherapist and gerontologist, her research bridges rehabilitation, psychology, and population health, focusing on mobility, aging, health behaviors, and psychosocial adaptation among older adults. Her doctoral dissertation, More Than a Misstep, Personality and Fall-Related Psychological Concerns in Aging, explores the interplay between personality traits, fall risk, and psychological coping strategies. Henrietha has received several awards, including the Prentice Graduate Research Scholarship and the Commonwealth Scholar Award. She is passionate about research translation that supports healthier aging trajectories, and she actively engages in interdisciplinary collaborations addressing mobility and psychosocial well-being across the lifespan. So let's get started. Welcome, Henrietha. Over to you.
So welcome everyone, and thank you for joining today's session. I'm excited to share findings from our recent paper published in the Journal of Applied Gerontology, focusing on personality traits and health behaviors and how they influence fall risks in older adults, using data from the CLSA. So here's an outline of what I'll be covering today. Now imagine it's a 76-year-old woman. Pictures, name is Margaret. She lives alone, enjoys gardening, and walks daily to the corner store. Now one morning, she trips on a loose rug and she falls. It's not just a bruise. She loses her confidence. She avoids walking outside. She stops attending her weekly church group. Now this story is not uncommon. In fact, 1 in 3 older Canadians fall each year. The cost? over $5.6 billion annually to the healthcare system. But beyond the cost, falls affects independence, affects mental health, and the quality of life. Aside from that, we know that falls are widely multifactorial. It involves so many risk factors involving the physical, environmental, and psychological contributions. And while we know that traditional risk models often focus on physical factors such as balance, strength, use of medication, there is growing interest in understanding how psychosocial and behavioral dimensions contribute to fall risk. Now, this is where my study comes in. I'm interested in knowing how personality traits influences how individuals perceive, interpret, and respond to psychosocial challenges, especially with regards to fall. Now, before we go further, I would like to define the traits we are working with. According to Costa and McRae, personality traits refer to stable tendencies in how people think, feel, and behave. It's commonly measured using the big 5 dimensions, which include openness to experience, extraversion, agreeableness, conscientiousness, emotional stability, and emotional stability, also known as neuroticism, which is people who are prone to worry and unstable. Now, we know that in as much as these personality traits are stable in the population, most people often score somewhere in the middle of each trait. And definitely we have natural variations across individuals and age groups. And in older adults, we often observe gradual shifts, like some persons become more cautious or less outgoing or more. And we know that these trait changes are typically slow and they are shaped by major life events, such as like an illness or the loss of a loved one or just aging in general. While behaviors, on the other hand, are more flexible and day-to-day like, such as how often someone exercises, drinks alcohol, or smokes. And we know that behavior changes happens quickly and may also reflect conscious choices or sometimes reaction to health challenges. Now, one of the models I tried to use to help me understand how personality behaviors influence fall risk is the health belief model, which suggests that people are more likely to engage in preventive health behaviors when they perceive themselves as susceptible to a risk and believe the benefits of action outweighs the cost. Now, when I mean by perceived susceptibility, I mean in the context of falls, an individual may perceive himself as at low risk of falling, which means that he has a high confidence in his ability not to fall. So they may not take precautions with regards to fall prevention. On the other hand, if an individual perceives the severity of fall as serious, as high, they may be motivated to act. Now, I try to reason that personality in a way can act as a behavior filter to influence how people perceive falls and how they act. For instance, a highly conscious older adult may be more vigilant and proactive. Subsequently, they follow routines, they adopt fall prevention guidelines, which is good. Now, someone who is highly neurotic, emotionally unstable, might overestimate their risk. So they can become anxious, thereby reducing their activity, which ironically can also increase their risk of falling through what we call physical deconditioning. Now, an extroverted person may also stay active and socially engaged, which is great, but they may take more risks as they move through unfamiliar spaces. So personality in this sense doesn't just shape the behavior, it also shapes the perception, the motivation, and how people adapt, especially when their health changes. This helps explain why two people with similar physical risk may behave very differently when it comes to preventing falls. So for our study, our objective was to, first objective was to test if personality and health behaviors predict future falls. And the second was to look at whether changes in these variables, that's personality and health behaviors such as quitting smoking or shifting traits, also play a role. And why this matters is that most studies often link personality to fall risks using static cross-sectional data. Our study takes a more dynamic view, tracking how changes in both traits and behavior unfold over time and how they shape fall outcomes. So this adds depth, directionality, and real-world relevance to fall prevention research. So we used data from the comprehensive cohort of the CLSA, and we focused on older adults 65 and above who had complete information across 3 time points, each spaced roughly 3 years apart. We excluded participants who had missing values on key variables like fall history, personality, or health behavior. Now, this was important to preserve the integrity of our statistical model. Including incomplete data could have distorted our findings or reduced our ability to detect real associations. On the flip side, it's also worth noting that excluding these cases might limit generalizability, especially if those missing data were systematically different. And when I mean by systematically different, I mean probably they were more frail or more physically active or less physically active or more cognitively impaired. Because, you know, with aging comes slight declines in cognition, which we know that. So the reason I took this step was to have a balance between ensuring accurate estimates and acknowledging some trade-offs in our samples. So in the CLSA, these were the key measures that my outcome was false, which was measured using a self-report item. And participants were asked the question, in the past 12 months, did you have any falls that resulted in limitations to your normal activities? Now, those who answered yes, we classified them as fallers, and those who answered no as non-fallers. While this is a commonly used method, it's important to acknowledge the potential for recall bias. Participants may forget or underreport falls, especially if the fall didn't lead to serious consequence. Personality trait was also measured at baseline and follow-up 1 using the 10-item personality inventory. And this scale captured the big 5 traits. Now, although personality is relatively stable, responses are still based on self-perception, which can be influenced by mood, the health, or social context at the time of assessment. Physical activity was also measured using the physical activity scale for the elderly, and like other measures, it was also self-reported, which on the flip side can introduce the risks of social desirability bias, where individuals may overestimate how active they are. Alcohol consumption, participants were asked about their drinking frequency over the past 12 months. And just as the CLSA, we categorized them as non-drinkers if they had no alcohol use, occasional drinkers if they had less than once a month, and regular drinkers if they drank more than once a month. Smoking was also classified into 3 categories: those who didn't smoke, those who were former smokers and quit, and those who currently smoked. We also try to track behavior changes, whether participants increase, decrease, or maintain their status, either their drinking pattern or they began smoking after the follow-up or they quit smoking. And this approach, trying to look at both baseline behavior and behavior change, gave us a more dynamic picture of how personality and health habits may evolve and interact with fall risks over time. In our analytical approach, first we began with descriptive statistics to summarize the characteristics of our sample, including fall prevalence, demographic details, and health behavior patterns. Then we ran a bivariate logistic regression model to test the association between one predictor and the outcome. In this case, whether each trait or behavior was individually linked to falling. Now, these bivariate models are often referred to as unadjusted models since we don't account for other influencing factors. Remember, I said that fall is multifactorial, so just few causes will not actually lead someone to fall. It has to be a combination of other factors. So to get a clearer picture, we also followed up with some multivariate models where we adjusted for potential covariates, which have been known as strong predictors of falls, like age, gender, depression, chronic conditions, and cognition. Now, this helps us isolate the unique contribution of each of the trait of variables independent of the other factors. And also, we also calculated the change scores, difference between baseline and follow-up for each variable, which allowed us to test whether changes over time are not just baseline levels predicted fall risk. Personality was also measured up to follow-up 1. Personality was only assessed up to follow-up 1, but not at follow-up 2. Why this may not be an oversight? It's actually quite typical in longitudinal studies because research has shown that personality traits tend to be relatively stable into adulthood. So we used both personality at baseline and follow-up 1 to allow us to observe both trait levels and short-term shifts without assuming frequent changes. So looking at our total sample, our sample after the inclusion and excluding participants who didn't meet our criteria was reduced to 5,270. Our sample was predominantly white, female, well-educated, with an average age of 72 years. And we can see that fall incidence increased over time from 5.1 to 8.7. And we can also see some shifts in alcohol use, smoking, and activity levels. These shifts in health behaviors will become important when we look at the analysis that relates to our behaviors. Now, looking at personality distribution across our sample, the chart shows how people's personality traits shifted between the beginning of the study, that's baseline, and a few years later. Now, the traits you see are parts of the Big Five, which for acronym we call OCEAN, and the dots shows the average scores for each personality trait. So the blue line is baseline, the green is follow-up 1. And the lines around each dot shows how much people differed from each other in our samples. So the longer the line, the more variation in personality traits we find between our sample population. Now, what did we find? Participants scored highest in conscientiousness at both time points, meaning that they were more conscious about structures, routines, being responsible over time. And this trait was pretty much stable. Although we saw some slight declines in traits like extraversion, emotional stability, openness, and agreeableness. While these changes were small, they were noticeable. And they may reflect natural shifts with aging, like people becoming less socially active, feeling more sensitive to stress, or becoming set in one's ways. Now, when we look at the variability, we see that traits like extraversion and openness had longer lines, which tells us that they varied more on those traits. In other words, while the average scores went down, some people stayed very socially active and open to new ideas, while others changed dramatically. So this chart reminds us that some parts of our personality stay steady, while others may change gradually with age. And even within the same age group, people differ, which means fall risk and other age-related outcomes may also vary depending on personality patterns. Now, when we come to our bivariate models, for the baseline, which was collected between 2011 and 2015, each model was tested against a single variable against fall occurrence with no adjustments. And we see that both current smokers and those who quit had reduced odds of falling compared to those who never smoked. And we see that those who drank occasionally were less likely to fall, while regular drinkers were more likely to fall. Although physical activity showed no significant association. However, all 5 personality traits were associated with an increased risk of fall, a pattern that might reflect baseline tendencies. Now, when we come to the follow-up period, this is like between 2018 to 2021. That's roughly 7 to 10 years after baseline. The findings show that the effects of smoking reversed. Now, those who quit had the highest risk of fall, while current smokers still showed lower odds. Probably they were motivated to quit smoking because of health challenge. And we see that those who never smoke still had a high risk of fall. Now, this doesn't mean that smoking is good. We know it's quite harmful in many ways, but in this case, probably those who never smoke may have been more physically active, thereby increasing their exposure to fall hazards. Now we see that those who were regular drinkers now appear to be protective, while non-drinking was associated with higher risks. Again, probably behavior changes may coincide with emerging frailty, because you remember that our sample is actually getting older, not younger. And we see a small but statistically significant protective effect for physical activity, which somewhat a little bit of an expected result, because we know the significance of physical activity in aging. For personality, we observed some shifts. Conscientiousness, agreeableness, and emotional stability now predicted lower falls, while extraversion and openness remain associated with higher odds of falling. Now, just so you know, this is still the unadjusted associations. It just gives us a snapshot of how these psychological and behavioral predictors relate to fall risk. When we factor in other covariates or other aspects of the person that have been known to influence fall, we can see some changes in statistical significance as we go on. Now, when we come to personality and how it relates to the risks of falling, when we adjust for the covariates we mentioned earlier, the left side panel A shows the relationship between the different personality traits and fall risk at 2 time points, the beginning of the study and several years later. The right side shows the actual changes in personality traits. Now, before I delve into the finding, I just want to give a quick explanation of the graph. Now, each dot on the chart represents the odd ratio. This tells us how likely a person is to fall based on a certain trait or change. If the number is above 1, it means higher risk of falling. Below 1 means lower odds. Exactly 1, no difference in risks. So we can see that being conscientious, that's being organized and disciplined, started out as slightly increasing from the graph in panel A, suggesting that these habits can prevent falls in older age. And it stayed relatively stable because it still became protective. Openness and agreeableness also changed direction over time, showing that the effect personality has on fall risk is not fixed. It can evolve with life stage or health changes. Now, what happens when personality actually changes? When people become less extroverted, they are 30% more likely to fall. This might be because social withdrawal sometimes often leads to less movement or less confidence. Now we see that those who became more conscientious were less likely to fall, about 12% less likely to fall, which fits with being cautious and well-planned, can help reduce your risk of falling. Now, interestingly, people who became more emotionally sensitive, that's people who were highly emotionally unstable, that's highly neurotic individuals, were also less likely to fall, but slightly. Now, this might seem counterintuitive, but there's something we call the healthy neuroticism effect, whereby highly conscientious and highly neurotic, emotionally unstable individuals are more cautious. So they worry about risky situations and they tend to be overly cautious in their behavior to avoid such instances. In this case, it's almost like their conscientiousness is doubled because of the worry behind it. Now, when we look at the behaviors for the multivariate findings, we see that at the beginning of the study, smoking wasn't clearly linked to fall risk, but by follow-up, people who still smoked were much more likely to fall, which can be expected. And we see that for alcohol use, both occasional and regular drinkers became protective over time, which may reflect light social drinking can be part of an active, engaged lifestyle. Now, the odds of falling for physical activity went up slightly with higher activity. While it might sound surprising, it could be because being more active can increase your chance of encountering more fall hazards. Like you're walking outdoors or exercising outdoors, you can trip on a stone and fall, and just because you wanted to be physically active. But then, it's small. The odds of that happening was actually small, but then we know that small changes can mean a difference between a serious fall and not. Now, when we look at the changes in behavior, we see that quitting smoking had the highest odds of falling, over 2% odds of falling, like 180% chance of falling for those who quit smoking. And this may be because oftentimes the older one gets, when they quit smoking, it's mostly because their health is declining, not necessarily that they want to make a change in behavior. And we also saw that decreasing alcohol intake was also linked to a higher risk of falling, which again might reflect underlying health issues rather than drinking itself. Now, we saw that becoming physically active increased that fall odds, which tells us that while physical activity is healthy, it's important to make sure it's done in a safe environment with good balance and good fall prevention strategies. Now, what's the takeaway from this? Behaviors like smoking, drinking, being active, they don't affect fall risk in isolation. The why and the how someone changes their behavior matters. And sometimes the behavior change signals another health issue going on in the background of the individual that we may not know about. Now, when we think about our findings from the bivariate and multivariate associations, we see that personality and behaviors could have mutual influence on fall risk, because we know that these behaviors do not occur in isolation. For instance, when we adjusted for personality traits, the association between current smoking and falls shifted from protective to risky, suggesting that traits like extraversion or emotional stability might have influenced the relationship between smoking and falls, beyond the effects of the demographic and health covariates that we accounted for in the model. The reverse also happened when we adjusted for health behaviors. Agreeableness flipped from protective to risky, suggesting that personality and behavior could have mutual influence on each other's risk, reinforcing the idea of interdependence rather than isolated pathways when it comes to fall risk. So, although we did not formally test for interaction or mediation in these our models, these shifts still indicates that personality and behaviors are important and mutually influential layers in fall risk. And most oftentimes, they operate alongside established covariates which have been known to influence and predict falls. Now, what can we take away from our findings? One of the most expected patterns we found was that individuals who reported healthy changes, like quitting smoking or reducing alcohol use, were more likely to fall. At first glance, this might seem counterintuitive, but in older populations, these behavior changes often happen, like I said earlier, in response to declining health, not just out of motivation for wellness. For example, someone might quit drinking because of a new medication he started, or probably he developed a heart condition, or an incident that already compromised his stability. So the change is not because of making a healthy choice, it's just because of the situation the person found themselves in. And we also observed a decline in extraversion being associated with greater rates of falling. Now, we know that extroverted individuals are often individuals that have high energy, like to engage in social participation and other physical activities. Now, when you reduce these traits, the reduction in these traits can reflect social withdrawal, maybe increased caution, or even early psychological changes that precedes physical decline. This is especially important in a population with wide variability in personality, where some older adults may remain socially active and others may just quietly disengage over time. And that's the key point. In our sample, we had meaningful variations in personality traits within the population, particularly in traits like extraversion and openness. So this variation means that 4 risks doesn't follow a one-size-fits-all pathway. For some, risk can come from overactivity or impulsivity. For others, from frailty and retreat. So our findings emphasize that we must view behavioral choices and personality changes in context, not just as static characteristics, but as dynamic signals, because when combined together, they offer a more complete picture of 4 risks alone. So how do we translate our findings into practice? Now, on the left, I have 4 key implications drawn from our data, from our findings, and on the right, I've paired each with an example of how it could play out in a real-world setting. First, we might enhance 4 risk screening to include simple personality markers. For instance, high neuroticism or low conscientiousness may flag people who might benefit from more structured support or behavioral coaching. Secondly, timing is everything. When someone stops drinking or smoking, that change may signal a health transition. So we have to flag those moments for extra 4 risk monitoring, because we know that these changes don't just happen. Something pushes the individual to make some drastic health changes. So we have to be aware of that, especially if you have patients undergoing probably physical therapy or rehabilitation in some form. You need to be able to flag some of these moments. And third, our public health messaging needs to feel more personal. Like, people high in extraversion might respond well to group-based programs because they like social engagement, while more introverted individuals might prefer something self-paced, home intervention. So we have to know when is the right time to prescribe what for our patients so that we can maximize the outputs we get. And lastly, transitions are danger zones. So when an individual is going through a transition phase, like probably after a loss of a loved one, hospitalization, probably long-term stay, or a relocation, both personality and behavior often shift. And that's when we need to intervene. Now, we recognize in our study that what we are capturing may not be deep personality restructuring, but from a fall prevention standpoint, this trait-related shift still tells us who may be at greater risk and can also help us tailor support accordingly. But despite what our study insights from our study, it's not without its own limitation. So in this slide, I've tried to summarize the contributions and limitations of our study. On the left, I've highlighted what our research offers. For one, it provides strong evidence linking personality and behavioral factors, not just at one time point, but as they change over time with the risk of falling. It also reinforces that these links are generalizable to healthy older community-dwelling Canadians, because our sample population is Canadian older adults, which is valuable given the size and quality of the CLSA. And this group were well represented in our cohort. But of course, there are limitations. As an observational study, we can't claim causality, so we don't know the motivation behind the behavior change, or whether quitting smoking, for example, was a health-conscious choice or response to an illness. We don't know that. So basically, we're just giving a hypothetical explanation of why we got what we got. And also we know that these findings support using personality traits in fall risk screening, but then we still need more work to understand the mechanisms, why certain trait changes predict falls and why some don't, and how best to intervene where we can come in. So in conclusion, I would just emphasize 3 core messages. First, traits and behaviors matters. Even more, it's how they reflect, traits and behavior matters because we know that falls are not random events. They reflect deeper patterns of how we think, how we feel, how we act. And we know that personality traits like conscientiousness or extraversion influences our daily routines, our risk perception, and our willingness to engage in fall prevention strategies. Second, what matters even more is how these patterns change. Our study shows that fall risk increases when traits like extraversion declines or when health behaviors shift, especially in ways that might reflect underlying decline. Now we know that these changes are not just changes, they are signals. And finally, the future of health prevention must be personalized because we need tools and policies that accounts for individuality. When we recognize psychological and behavioral cues, we can intervene at the right time with the right message for the right person. We move forward if we want to have a truly meaningful, person-centered fall prevention plan. Individuality is the key. So I'd like to thank the CLSA team for helping fund this research, for providing the data set available. And this work was a collaborative effort supported by great mentors and colleagues. Thank you for listening. I would like to hear your thoughts on how you think these findings could help you. Thank you.
Great. Thanks so much, Henrietta, for the excellent presentation. So yeah, we'll open it up for questions. We've got a couple queued up. But first, I just wanted to ask how did you first become interested in looking at personality traits in this context?
Okay, I for one, I'm a physiotherapist. I've practiced for over 6 years, and most of my clients were older adults who had so many fall-related injuries. And it got me thinking because what I do for one may show promise, like getting better, and then the next person just finds it so difficult to adhere to some of guidelines. And it got me thinking, like, okay, what if I try to take a different approach because their personality differs? So if you try to tailor your intervention to a specific personality that you know is probably dominant in your patient, probably you can see more output. Like I had one patient who was overweight, and then they were trying to see how they can cut down on her eating habits. And one of the things her daughter suggested was that she just loved to eat apple. Apple is like a traditional dish. It's high in carbohydrates and fat. So, and she eats it at odd hours. Like she can eat it 2 a.m. She just loves that. And then the daughter says she has tried to, lock the kitchen, do stuff like that just to make her to stop that. But it doesn't work because if she doesn't eat it, she can't sleep. And I'm like, okay, there are other ways you can go around this dieting. If this won't work, you can't just try to force it. You can try to say, okay, maybe you can allow her to have it, but probably earlier up in the day. And then maybe she does some form of physical activity before she goes to bed so she can burn off some of those excess fat. So this just got me thinking, like, how do I make my patients adhere better to routines so that they can see more good outcomes, not just you having physical therapy and then you're not seeing any result and then you get frustrated and then you stay back home, but then you're not getting any better. So that's interesting insight. Yes.
Oh, great. Thank you.
You're welcome.
So we have a question. So thank you for sharing your interesting study. Have you tested other statistical models You may find different results with other testing models for longitudinal data, especially for events. The logistic model is quite powerful when testing events from cross-sectional data.
Okay. Yes, I was open to that, but then because my outcome was false and the way that false was measured in our data was kind of like limiting. Like, for instance, why the questions were like in the last 12 months, had you had any falls? Now, in a way, sometimes because people have to think about the 4 habits in the last 12 months, and then you come again after like 4 or 5 months, and then you 2-3 years, and then you ask them in the last 12 months, have you had any falls? So sometimes they may just be limiting how they are picking up their falls within that time point you ask them. Now, if you look at our data, you see that while we had fall increasing, the number of people who recorded a fall was actually few. And then when you look at number of times they actually fell, it was sometimes they usually tell you like once or twice, mostly in the figure of counts of 1. So looking at, because the fall outcome was our outcome variable, it was a little bit limiting in trying to explore other methodological data that could help us to stratify in over time. So what we tried to do here was just to account for fall changes by using the baseline as last predictors in our model to just account for those changes. I understand that it can be limiting, but then that was the approach we had to use.
Thanks.
You're welcome.
Next question. Thanks for sharing your valuable research and interpretation. As a registered dietitian working in Canada, I wonder if you looked at nutritional status in your study. We believe it is an independent predictor of falls in older people in the community and should be addressed in a fall study. Thanks for considering.
Yes, definitely. Like I said, fall is multifactorial, and there was just so much of the predictors that we couldn't account for. We didn't account for nutrition. I understand that nutrition is part of that, but we didn't account for that.
Okay, thank you. Next, could you suggest an approach to reproduce the study using a retrospective study design in another region?
Now, to reproduce this study in another region, one thing is because this data we use, the data set we use is a longitudinal data set, and most of the variables that were measured through observed data. So if we want to reproduce this in a different study, first we have to have a similar kind of longitudinal data, which have some of these variables we are looking at. And then one thing we should note is that some of these large data sets, when they collect variables, they don't collect it in relation to, let me say, fall. Like the CLSA didn't collect all these variables because they wanted to look at falls. So they just collect everything at random. So sometimes it depends on the motive and design of the data set that you have and what they collected from, because sometimes trying to imagine why this influenced that outcome is not always straightforward, because the designs of the data set and what they collect, you know that the variables that are being collected, it's not like it's mutually influencing. So in a way, it may be difficult to replicate, but then again, if you have a longitudinal data set and you have all the statistical variables that we used, you have it, then you can easily replicate that following our methods.
Yeah, or you could, design a study focused on that using the same methods, but expanding on those kinds of things you talked about. Yeah. So the next question is, will your research continue in the future in order to understand the mechanisms behind changes in behavior and the risk of falls? Is it possible to carry out the same type of research on a more diverse cohort?
Oh yes, like this is something I'm passionate about and what I intend to look at in my postdoc, because I know that these findings that we got, it's just signals or something, but then, we take it with a pinch of salt because there's so many variables that we couldn't account for. So, like, for instance, in as much as I'm advocating for, we have to put personality assessment in 4 weeks, I would like to test that out, like, in a randomized control trial unit. Like, for instance, actually design an outcome where I actually take into people's personality and use it to design a person-centered approach. So I could have like my control group and people who have the real approach and then see changes. So I have to have people who have similar underlying health issues, similar characteristics. We know sometimes it's not so easy, but then we just have to try and account for as much of the variable we can and see if the results that we will get will be that productive. So definitely I'm much interested in see how this can go further. Like, for instance, we know that fear of falling is something that could have influenced highly neurotic, highly concentration individuals to have more falls. So, and we know that we don't have much assessments for fear of fall in terms of practical fall prevention guidelines. How can you help someone who has a fear of falling to actually prevent falls? So I'm just so interested in it. So it's something that I see myself doing further down the line, yes.
Yeah, that would be interesting. Next, the finding about moderate drinking is very interesting. I notice your paper advises educating people about the benefits of moderate drinking. Should health practitioners really advise people to drink moderately if this could increase risk for other events or illness?
So like I said, someone drinking moderately may not, it could be that he's doing other things aside from moderate drinking. Probably he's not physically active, or probably he has an underlying health issue. But we know that so much of research out there has shown that moderate drinking can actually help you, because in one way is that people who moderately drink are usually occasional drinkers, meaning you go for occasions and you have like a can occasionally. So being socially active, going out there, it's in a way it's giving you a form of making you being active, and in a way it can help you reduce your fall risk. But then again, all this is based on people's individual personality. Someone that moderately drinks and then it's not someone that likes to exercise, it's not someone that likes to go out, then they can have increased fall risks. On the flip side, if the person likes to go out and exercise and do other health behaviors that can counteract the effects of his moderate drinking or not, can also help reduce falls. So individual.
The next one said, I'm surprised you didn't include change in frequency of falls. Was your outcome variable simply one or more falls? And how do you justify that?
Now, that's what I was trying to explain. For change in frequency of falls, we have to know if we have to know if the people who fell were single or recurrent fallers, for you to know if you had a change in frequency of falling. And when we model this for the multivariate model, like I said, to account for the change in fall frequency, we modeled with baseline falls. So for instance, when we're throwing it into the model, our predictor will be like maybe falls at follow-up 2. And then when we throw in other factors inside, we still throw in baseline falls to account for the change in fall. So we actually did that.
Okay. And then the next is, I see this work has a lot to do with an inclusive approach towards healthcare. Thank you for casting light on this. Do you think considering personality may increase the time it takes to screen fall risk among older adults compared to the current time it takes to screen for fall risk among older adults in Canada? So does considering personality increase the time it takes to screen fall risk compared to what's currently done?
So definitely it's something you are adding into what you're already doing. So you're gonna have to spend a little bit more time. And that's why we have so many brief questionnaires that, like the personality questionnaire that was used in this study, the TIPI, it's very brief, 10 questions, something you can answer within 5 minutes, 5 to 10 minutes, depending on how you want to think. So in as much as it's going to increase time, because I know when you have a patient, you are under time constraint of how long you can spend with that patient. Yes. But then, you have to factor in the fact that you want something that is beneficial in the long run. So if you can add a little bit more time to see, oh, will this make a difference in how my patient improves or not? I think it's something, like I said earlier, we'll just have to try and check the feasibility of something like this when we do like a trial and see, okay, even if it increases the time, does the increase in time warrant in effect to the benefits it has? What's the gap there? Like, is this something that is more beneficial or time consuming and the effect is not much? So that's something we can see for future studies.
Right, right. Okay. We have another one. Do you see any correlation between increasing hearing loss and falls? My hearing aid specialist has adjusted my hearing aids to focus on noise speech directly above my ears. There is a considerable difference in what I process between my right and left ear.
So yes, like so many studies have shown that hearing loss and problems with hearing increases falls, because when you're moving out, if you stumble, for one, your whole senses is attuned to trying to make you not to fall. And imagine if there's a blackout, or probably you're not hearing well in one ear. Probably maybe if there's a moving vehicle or like a bike lane, sometimes it's just similar with people who plug their ears and they're walking. If a bike is honning, you may not hear until probably it's very close to you, and then your reaction time is not so. And then we also know that the ear has been shown to help with balance. So yes, it's very much influences falls.
Great. So yeah, did you incorporate hearing loss
No, I
in
didn't.
your study? But okay, got it. Okay, we don't have any questions left in the boxes, but we have 2 minutes. So if anybody wants to slip in a last minute question. Oh, I see there is one. Okay. I think there are more I think there's more research to flush out if personality would be implemented in fear fall intervention or assessment. I think a huge co-creation approach would be useful, as healthcare workers would not want additional work in fear falling assessment intervention. However, co-creating with healthcare workers to figure out where to apply this would be ideal and can give them ownership and increase applicability. Do you have any comments to respond to that?
Yes, and that's the same similar idea that I have. Anything that has to work, you have to co-create with the health professionals, because these are your target populations that could help these people. So yes, we have to co-create them. And just like when you do co-creation, when you give them ownership of what you're doing, it makes them more inclined to be involved and do that. So yes, I definitely align with that.
Great, thank you. One last one. Oh, sorry, there was a comment. Thank you for your work. Your research is valuable. And then one last question. Do you plan to conduct some extra analysis to see how these variables affect your outcome and predictor, like a mediation analysis in the future? So I'm
Oh
assuming
yes,
that's
so
referring
that's
to
one thing that,
hearing.
yeah, sorry. Okay, so that's one thing that I noticed about the mutual influence, and I'm really passionate about knowing if I could isolate the mediators, if personalities actually mediate that behavior for interactions and vice versa. So this is something that I intend to do, probably, but I didn't do it in my study. And one of the reasons is because I just had so much ongoing.
For
And
sure.
so yeah, so that's something that I intend to do further. Yes.
Great. Well, I think we'll wrap up there. Thank you so much, Henrietta. We really, yeah, appreciate you joining us today, and for all the participants who've joined as well. We appreciate you being here. I'd like to remind everyone that the next deadline for data access applications is July 9th. 2025. So please visit the data access section on our website to review available data, as well as additional details about the application process. I'll also add that with the holidays coming up, and summer schedules, that our response times in the access inbox might be a little longer than usual. So if you have any questions as you're preparing your application, just get to it earlier than later, I would recommend. And also a friendly reminder for all CLSA data users to keep us updated on any changes that affect your data access agreements, such as have you moved institutions, has the research team changed, has the trainee graduated or moved to a new position. Again, just reach out to us at access@clsa-elcv.ca with any questions or updates. On another note, our manuscript review process has now moved to Magnolia, and that was highlighted in our last newsletter. So if you are submitting a manuscript for review, which is required before submission for publication or preprint, please do so through Magnolia. So last reminder, please complete the anonymous survey upon exiting the Zoom session. Now this completes our winter-spring webinar session. We'll be presenting a new series of webinars beginning in September, and the details will be available soon on our website at clsa-elcv.ca /webinars. And the registration details are posted on our website in that spot as well. And there's links in the chat box for everything I mentioned, and including the survey. So thanks again, everyone, and have a great rest of the day.